We're back from break, Liz, and we've gone over the IV board. I'll show you, and then now one more hormone, the somatotrophic hormone, STH, or growth hormone. That now, before I go on, I want to talk one more thing on the thyroid stimulating. And I think we've already said this a little bit earlier in the 7 weeks, but listen to the name, thyroid stimulating. It's not thyroid. When people are getting synthroid, they're getting T3 or T4. They're getting the product of TSH, and so it's a thyroid stimulates. It stimulates the thyroid to produce thyroxine for metabolism or whatever. And that doesn't have anything to do with calcitonin. We've already gone and beaten that one to death, calcitonin. But the thyroid stimulating, the hypothalamus says, oh, you hadn't got enough thyroxine. So it tells TSH, it tells the anterior pituitary, TSH, give it a shot, and TSH makes the thyroid produce more. It can be too little or too much, and there's where we have hyperthyroidism or hypothyroidism. And so I want to just say a minute or two more on that. We don't need to go over symptoms. You can figure them out. If you're low metabolism, you sleep, you know you're not too active. If you're hyper, you're overactive. The problem with hyper is your heart, because if you're so active, that thyroid is putting that metabolism to, and you get arrhythmias and then maybe failure. The two Bushes, Mr. and Mrs. George W. and his wife, both had it, and you know, she had some more symptoms besides heart. He didn't get the exophthalmos, where it's too much. So if you've got too much thyroid, if you have too much thyroid, you're putting out, your thyroid has gone bizarre, and it's putting out too much T3 or T4, and I don't distinguish them because you don't need to, and we don't need to. But it is thyroxine. And it is what you're getting when you give a pill, Synthroid or thyroid pill. You're not getting TSH, you're getting the thyroid. Synthetic thyroid, Synthroid. If you have 3 symptoms, you have Graves' disease, and that is hyperthyroidism. And the 3 symptoms are exophthalmos, heart, and rapid tachycardia. There we go. Rapid heart tachycardia. And then goiter, and it's a uniform goiter. It's a thick neck. Let's just cut the fancy words. You've got the thick neck. And it's thick. I've visited with people, and I don't, you know, you probably, it doesn't surprise you that I've said, have you ever had your thyroid checked? Because, you know, it's out there. And you'd be visiting with somebody and you notice it. But I do think we have we've been so conditioned for assessing that I just assess all the time, and I know you do too. I can tell, people say I've had my glasses 3 weeks and you're the first person to say anything about them, or you know, and it's because that's what we do. Diamond rings, I'll say that's the prettiest ring. Well, I've had it for 8 months and you're the first person to notice. My husband gave me a new ring, or whatever. But I think we just got a different sense when you've been into this profession. So I'm not through. I'm still beating on that thyroid business. So those 3 things are hyperthyroid, and something needs to be done. And because you cannot live with your heart doing that, you're going to die of heart failure. So it's, what are we going to do with hyperthyroid to stop that? They kind of want you to run its course. If they'll watch, I know President George Bush, they just watched him, and if his heart ever showed any problem, they would have removed it. You can remove it. I mean, we can do a thyroidectomy. The world can. You kind of hate to if you don't need to. So they try to see if it'll run its course. If it won't, they can give you saturated solution, SSKI, saturated solution of potassium iodide. It's drops, and it diminishes vascularity, which then makes smaller vessels, which will, apparently the thyroid's very attuned to that, and with less blood supply, maybe it won't be pouring out T3, T4. So SSKI can be used, removing it. We got to get rid of it if it's going to take your heart. So they watch you. The president, George Bush, didn't need it. It began to fizzle out and lost it. I mean, it cannot sustain itself. Hardly anything great can. And great speed is not going to sustain itself. It's going to die eventually, and it does, if your heart doesn't first. You're going to have it removed if it's starting to bother your heart. But those are your three. And now, too low, you're just somnic, you're tired, you're no energy, and we can give you Synthroid, and that's a great thing that we've got that. I mentioned the Gorder for hyper, but there is a Gorder, I think it's confusing. Hypo has a Gorder too, but that Gorder is unilateral. It comes on one side. We call the Gorder for hyper bilateral because it's just a thick neck. But if you've got the Gorder for hypo, it's off to the side. And I tell, there's no reason to tell it, but I do. I may have already told you that if I go antiquing down at Bershawa Springs, I did one time with some friends, and we went in an antique shop, and the woman, I mean, it was her home. I couldn't look at the antique. She wore a little apron around her Gorder, and it matched her dress. Well, I couldn't even look at the antiques because I kept thinking, God love you. You live how far from medical care? We could get rid of that thing, give you Synthroid. And you knew it was quite a thing with her because it matched her dress, the little apron. I just ate. I wanted to do a teaching moment, but I didn't think it was appropriate to make that antique trip a teaching moment.
It's like someone not saying you have broccoli.
Yeah, right. Well, and they are unilateral, and they'll go down quite a bit if you get your Synthroid. One other little thing is the iodine. The thyroid needs iodine, and sea salt doesn't have it. Everybody raves about sea salt, but you're getting that little bit of iodine you need if it's a salt that has been given, or whatever it's called. Yeah. Some iodine. Now, so they have to decide, you're tired, I'm just lazy, I don't want to do anything. Well, that probably is the thyroid, so they run the test, and if your thyroid's low, do you get it? They don't know whether it's a problem here or here, and they've got to decide. So they they've got to decide, have we got a problem with the stimulating hormone is not stimulating enough, or is the thyroid been so bombarded with antibodies that it isn't functioning? And so they run tests on TSA. If TSH is normal and you're hypo, then we got a problem here. So that's what they have to do. If it's way off and it's low, we know this is probably fine, but we've got to do something about the stimulating hormone. So they usually will just go on and give them Synthroid and let the thyroid die, which is what it's going to do. If it's not being stimulated, it atrophies. Anotrophy growth. So it will atrophy and you'll be on Synthroid for life. So now, let's say you're hyper and they do TSH and it's normal, then we know the thyroid is acting up. So it probably needs to be removed because the TSH is fine, and I don't know, they don't know what to do to get this to react to TSH. It's probably been bombarded, has a virus, something has made it malfunction. So I just wanted to make sure you're very clear on hyper and hypothyroid, and it could be TSH problems or thyroid problems. Okay, so when I was in graduate school at Vanderbilt, I was given a patient who, I was on the endocrine floor because it was in research, it was a fun floor, it was where I wanted to be. I wanted to be there. And the woman that was my patient was a gym teacher. She was in her late 40s. I mean, she was alive and well, and dying wasn't an issue with her. She was in because, here's her story. She is in her 40s. She's plump. She's plump. And she told me 3 years ago, carpal tunnel syndrome. And you know what it is, hurting in the wrist. And the treatment is always odd to me. It's just clipping the nerves. And that worked. And she was fine. And, but I think she got it again. And so she knew she just needed to go get clipped again. Well, she doesn't say the doctor went aghast when he saw her. He didn't tell her that. He didn't tell her she looked different. And what it was is she now we can look back. She was having to change her tennis shoes. They just don't make them as good as they used to. The sides break down. She's a gym teacher, so she's pounding the gym floor anyway. And they don't make good shoes, or she's got her children, and she's spending less on her tennis shoes than her children. But now we can look back and see that she was buying tennis shoes pretty often. And that we had. She went to him because of the carpal tunnel. But when he saw her, he could tell she looked different. As I said, he didn't go, oh my goodness. He didn't do that. But what had happened to her is her teeth had spaced and her jaw. Now, I wonder where the husband was. But when you live with somebody, you don't notice little things if it's slow. But her jaw was protruding some down here. And her teeth were separated. Now, did she not notice? I don't think so. I'm not sure I'd notice if I floss, and I guess it'd be easier to floss or something. But she didn't really notice any difference. He did. The physician told her he could tell she looked different. So they did tests. And her and you may have guessed it, her growth hormone was high. And so the pituitary is pouring out STH. And so where does it go? It doesn't go to long bones, it goes to her cartilage. So anywhere it was soft is where it grew and was pushing. And so that's why her teeth were separated, because everywhere that was able, soft tissue that was cartilage, the growth hormone went into it. So Vanderbilt was not doing, see, this is nearly 50 years ago, a little less than 50. Vanderbilt was not doing hypophysectomies, the hypophysis, pituitary ectomy, taking it out, and Vanderbilt wasn't doing them. So we put her in the plane, and she flew to Rochester, Minnesota. Where's Johns Hopkins? Is that Baltimore? She went to Baltimore. Yeah. And so, do what? Mayo Clinic, that's right. I think she went to Boston. And this is where, give them as much money as they want, physicians. They did a transsphenoidelectomy on her. And that is, they incised right here and went up through her sinuses to the pituitary, remember where it is? And they lasered her pituitary and came back out, so we're up, and she flew back to Nashville for me to take care of her. And the post-op, I've got to take care of these hormones. And so, that are up on the board, Liz.
That was definitely before managed care.
Yeah. So, they left her posterior when they lasered her anterior. They left, so she wasn't going to have more children for Pitocin anyway, but ADH is pretty important. But they could have taken the posterior and it'd been all right, because it's made up in the hypothalamus. It just doesn't have a storage bin. So but she's going to be fine with those two, ADH and two. She isn't at first, and I'll tell you what we have to do first. Growth, she's through. Thank you very much. She's through growing, so we don't need to worry about that. Her pigmentation is set, so we don't need to worry about that. Let me come back to the PTH. The thyroid stim, they're just going to give her Synthroid. You and I are carrying, I think, 100, I read something different about every 5 years, that we store about 6 weeks worth or 100 days of T3, T4. But nobody wants to. If you have a thyroidectomy, they start you on Synthroid. They don't want you to deplete your supply. So she is going to have Synthroid. She not going to have any more children. If she wants to go menopausal, she can, or hormone replacement if she wanted that. I'll put hormone replacement if she wants it. Now, parathyroid, she would get some calcium, and they would probably check her if she needed iridium. So she's not in too bad a shape at this point, for life. Just mostly thyroid, and if she wants a hormone. Post-surgery, we've got to speak to her fluid. Well, I know we've got fluid regulators elsewhere in the body, but we need to speak to that. And if I can remember to come back to her, I will. We'll come back to her. But let's take the other patient I wanted to talk to you about. So we'll wait on Violet. That's Violet. Who lived through everything and great and couple of years later, I was in the mall and I heard her say, "I hear Lydia's voice." So anyway, it's what you always want to be remembered for. So anyway, the other patient was in the hospital, and I was working in the intensive care unit at this end, and the third floor, it was third floor. Intensive care at one end, just regular med surg the other end. And the nurse in that unit was, I'd see her at break or whatever, and I knew her. And she would come down, because night nurses, a lot of time they have to weigh patients. And so it was nights. And she'd come get our scales and go weigh her patients, and we'd visit or whatever. And so one day she said to me, I'm going on a diet. And at some time visiting over the time frame of getting to know her, she said she was my height, but she carried more weight than I did. She was well proportioned, but she was fleshy. And so, but not morbidly obese or anything. But she said, "Oh, did I tell you I'm going on a diet?" And she said, she was 26 years old then, and she said, "My husband has issued a little bit of an ultimatum that he wants me to lose my weight because this isn't the way I looked." And she looked great to me. I mean, fine, but not to him, I guess. And she said, "I hadn't always had this weight." She said, "It's done it in 3 years. We've been married 3, and he said it's enough time for my grieving." She said, "What happened is," she said, "my daddy, I went with him twice to the ER with esophageal varices. And if you've seen it, it's pretty upsetting. It's upsetting if you don't know the person, and if you love them, and they're projectile gushing and die." Well, the first time he did, but the third time he died with esophageal varices. And it's been hard for her. And so for 3 years, it's been hard, and that's when she gained her weight. And she told me, she said, "I was your size, but I've gained all this with grieving." And he's been very understanding, but he says it's time to work on other areas. And so she loved him enough to not slam the door in his face and leave him. So she said, "I'm trying." Now the bad part is she doesn't like anything but beans and franks. She doesn't like salad. She doesn't like fruit. And this is not good if you're needing a diet. So I said, "Well, Leanne, are you going to be able to do it?" She said, "Well, I'm going to try. I mean, beans and franks." Now, the thing is, she's getting her fat, so she's going to take vitamins. So she's going to get her A, D, E, and K. A lot of dieters don't, because they don't eat fat, so they don't get A, D, E, and K. They can take all the vitamins they want to, but if you don't have ones that are fat soluble, they just go out in your feces and urine. So she said, "I'm doing vitamins, and the fat in the beans and franks will do fine." So it was a few weeks later, and I would work just off and on. And she came one morning into the ICU, and her hair was cut. Now, she had olive skin and that wonderful lush hair, which the coloring kind of pristine. And that hair and so she is walking. I see her across and she's doing this with her uniform. She's lost weight and cut her hair. And I said, "Oh my, you have lost." She said, "Yeah, cut my hair too. Can you see that?" I said, "Well, yeah. I mean, it looks good. I loved it long too." She said, "Well, that's the interesting thing. It's coming out." Mm-hmm. Oh, wow. And she said, "Now, why do you think that?" I said, "Don't you think it's your diet?" And she said, "Well, I've been wondering, and I am going to go to the doctor and see, kind of be checked, because it just comes out. And so she went to the doctor, and here was the symptoms she gave him. Weight gain, but, she's losing it. But that's one of the things going on in her life is weight gain. And then alopecia, loss of hair. Hirsutism, is too much hair. So she's alopecia. And sexual libido. I mean, when somebody doesn't think you're very attractive, that doesn't. That might have a little just live with the sexual libido. And so that was kind of that. She didn't tell the doctor this. She and I had since. She didn't tell him that her pigmentation was off. But olive people do this, olive complected. Their bony prominences can get dark, and they're not dirty. And she would wear her stethoscope around. She said, look at this. She told me this at some point in our visiting. She'd say, I get so sick and tired of my elbows always looking so dirty and my neck looking dirty. I try not to wear my stethoscope thinking it is dirty. And, well, we now could look back and say her pigmentation was off. But you don't go in and tell a doctor my neck's looking dirty. And so her pigmentation was, I shouldn't say off, but it was prominent. And as I said, I think it's normal that olive people have the dark prominences. So she said, I went to the doctor. So the story is, she went to the doctor shortly after she talked to me, and told him this, and he said, it's nutritional, I'm sure, which is what you think, because she told him what she eats. And so he said, I'm sure it's nutritional. She was on a multivitamin, and I didn't know this. I knew that then you couldn't get a prenatal vitamin over the counter. And I don't know why they didn't, because what's the difference in prenatal is minerals. And I don't know, did they think we were going to get stones in our bladder or what? But you could not get prenatal vitamins over the counter, so he gave her a prescription. He said, I think you might be some mineral depleted or something. So I'm giving you a prescription for prenatal vitamins. As I said, you can get them over the counter now. So she said, I've got my prescription, I'm riding home, and at the red light, I put my hand to my chin, and I realized I didn't tell him. She's 26 years old, never had a baby, so hormones haven't been crazy, and I have stiff hairs. Now, she didn't have a whiskers, she didn't have a beard or anything, but she didn't used to have whiskers. Now, before any of you run to an endocrinologist because you've got some whiskers, it just happens, especially if you've had surges of hormones. Now, my husband and I have a little agreement, and I hope you will, if you know I'm in a nursing home, would you slip a little tweezer in your pocket and, come on. And so Sandra in the nursing home well knows shit.
That's what red lights are for.
Do what?
That's what red lights in your...
Yeah. So, this wasn't right. She's a nurse, and she wasn't upset, but she forgot to tell him, and by the way, I have some whiskers I never had before. And so when she got home, she called him, and he said, you need to come back in for some tests, because you can't say nutrition on that one. Now, you can say mental, husband not loving you, eating and not eating, but you can't say food for that. And so he ran the tests, and the one that was off the board was her cortisol levels were high. Well, let's stop just a minute and talk about the cortisol. You've looked in the handouts I gave you, we looked up steroids and everything about them. Not everything, but and all the pills of steroid do just what our steroid is doing on the cortex. And I call it the coping, C to the third power. Cortisol, the coping chemical. It's what helps us cope. It's what keeps us from jumping into an arrhythmia when we see a wreck at the side of the road. You know, you see it and your heart does kind of that. Well, it'd go to an arrhythmia if it didn't shoot out cortisol to keep us stable, keep our heart from going to arrhythmias. It's the homeostatic hormone. It just keeps us right where we should be for our body to function properly. Stress, you know, will shoot it up. It shoot cortisol up. That's what's up. Now, you already may be thinking ahead. Where is her problem? Is her problem here in the cortex, or is it up here? We know it's probably in the hypothalamus because everything else is working fine. So is it the pituitary has a problem, or the cortex has a problem? So they've got to try to work with her and see what it is. So she goes back to the doctor, and the thing is, they can do scans now, and so they scanned her and realized that her cortex looked fine. So we know now the problem's up in the pituitary. So she had a scan or whatever. The doctor said, we're going to scan your pituitary, and we think you have a little tumor, a lesion. And he described it as a grain of rice. You may have a tumor of a grain of rice sitting on that black-eyed pea. And it's sitting there pushing on ACTH. You say, well, what about salt and sex? Well, we've got other spots of the body working on that. And who's to say some of her weight isn't her fluid? So this grain of rice must be pressing on that ACTH. Well, they ran a scan and they didn't see a grain of rice. And so then the physician, I thought it was interesting and it was a good explanation. He said, then we're going to change our statement and say the lesion is still there. You've got a lesion, probably, a tumor, but it's probably like a drop of butter. And that drop of butter isn't showing good on the scan, but it's pressing on the ACTH part of the black-eyed. So they knew surgery was in order. You can't live with your cortisol level that high, and so they're going to go in and do an apophysectomy. And by that time, Nashville was up in times, and they'd do an apophysectomy here. We didn't have to put her on a plane to go to what did I say? Hopkins. Yeah, John Gaston, that's Memphis. Anyway, so they did an apophysectomy on her. And so went in and go up, and I talked to the doctor, the physician, afterwards, and he didn't describe it as a wilted balloon, but when he told me about it, I visualized, and here's what he said. When they got up there, her pituitary was wrinkled and withered over here, blown up over here. It was like a balloon that had been blown up. That's my description, but when he described it, I thought it was like a balloon. And 3 days later, the balloon's over here in the corner, and part of it's wilted, and part of it's blown up on the side. And it was big. It wasn't a tumor then, and I don't know why the scan didn't show that, and I may be making it sound bigger than it was. They lasered it out, or took it out. And then he said, because it had grown into the tissue, so we scraped, and we scraped and scraped to try to get any cells off the tissue, and we did as long as we could scraping, came out, sewed her up, and said, we will never go back. There's no reason. So they knew it might not be successful. I didn't, she didn't. But he made that statement. We said we'd never go back. We'd done all the scraping. If they did more, they would have gotten to the brain or whatever, so they couldn't go back. So now she's got to recuperate. And so the healing, even though the mouth is so full of germs, it heals nicely. Put a little salt in it and gargle salt, and it'll heal so well, so vascular. So what does she need? Now we talked about Violet and what she needed. Violet just needed these two things. Well, they both now speak to the ADH. And so Leanne does want children, and she asked about that, and the doctors, a fertilitist at Vanderbilt, said, you can have children. You can't do it without me, but you can have children. So she wants to keep everything alive and viable and ovulation going. So, and ADH isn't even made, they lasered, and I mean, they took it all. So she doesn't have a storage place for her ADH, but it's made in the hypothalamus. So here's what she does for the first few days. And I nurse a couple of patients who have had apophysectomies, and they're fine. They're walking around, they're fine. You've just got to keep up with the specific gravity of their urine. Because of the ADH, you've got to keep up with everything else too. But let's just take the ADH, and this is the interesting thing. So those patients are ambulatory. I mean, they just got this, and hormones that aren't immediately devastating. So they usually keep their own record. They keep a record, and I always say it's so interesting to me. The glass test tubes that are on the feet or on a round foot, and you had them in chemistry, and the stirrer, that you would read the meniscus, the curve at the end of it for the specific gravity. They come out of storage, I think, because they don't want to send every urination down for checking of specific gravity. So they've let, I don't know if they're doing it now, but they would let patients keep that test tube and the stirrer, and every time they urinate, keep a record of their specific gravity. Of course, it's going to be 1 at first, because what's the anti-diuretic doing? It's
not saving.
yeah, because it's not it's diuresing and not anti-ing, and so it's got a 1. Well, that's not good. She doesn't need to be keeping her waste in her bloodstream, and so out comes DDAVP. It's in your thing. DDAVP, which is the anti-diuretic hormone. When Leanne did it, it was only in sniffing, like an Afrin, and the physician's order was 4 inhalations, each nares 4 times a day, keeping a record of her specific gravity. And it just seems, it's not biblical, but it seems to take the body about 10 days to get over a shock like that. And that was a shock to the body. And so she keeps her, and all the 3 patients I've ever talked to or nursed, about 10 days it settles in, and the ADH coming down from the hypothalamus, clicks in. It doesn't have a storage space anymore, but it's on demand. And then you've got, so you've got the kidneys trying to regulate as well. But we'll get to the cortisol in just a minute. So she's got to have ADH probably for about 10 days. And and the minute it's really a fun thing to see the specific gravity start going up as you're given ADH. And now ADH comes in a pill form. Then they said it disintegrated with acids of your stomach, but they came up with something that now you can do both or either ADH pill or ADH sniffing. Pretty soon her specific gravity came up and she didn't need to do ADH anymore. So she doesn't need ADH. All right, if she has a baby, Pitocin and lactation all can be worked on. So right now, all she needs is ADH, and she doesn't really need that right now. She does want a gonadotrophic hormone because she wants to keep everything going when she is ready for baby. So she's given a birth control pill because it has Premarin and progesterone, not Premarin, estrogen and progesterone. So that's one pill. So far one. She needs Synthroid. We're just going to forget the TSH and go to Synthroid, the synthetic. Okay? So that's not too bad. She'll be just given calcium for the hair. She doesn't need the melanocyte. She's already pigmented. She doesn't need that. She doesn't need growth, or she's a grown woman. Here's going to be the book. Does anybody ever get ACTH? The only one I ever know is President John Kennedy got it because he didn't have enough cortisol. He didn't have enough, and when you don't have enough, it's called Addison's disease. When you have too much, it's Cushing's. Do you remember that now? And that is cortisol related, and it's a problem with the cortex or with ACTH. Kennedy, President Kennedy, unbeknownst to us at the time, his doctor was with him everywhere, flew with him because stress. Cortisol is stress, and if you don't produce enough cortisol, it's so hard on the body, he had to be given cortisol, but the physician would give him, cortisol only comes in injections, and it's very thick and very oily. We don't give it. I've given it once in my life. They'd rather just give cortisol, the end result. You say, well, what about the other things? Well, water is taken care of with ADH and kidneys and so forth. And androgen can be taken care of with the other hormones. So they just give cortisol. And so what happens then with Leanne's cortex, it will atrophy because it's not getting stimulated. She's not going to get ACTH to stimulate. She's just going to go on and get cortisol. So she's going to have cortisol. Now that's all she needs, and it doesn't look bad. So she gets birth control pills, thyroid, and cortisol. The birth control pills and the thyroid are easy. It's the cortisol that is really going to be the problem. I told her, she was back at work, and she was a night person. Her circadian rhythm was night. And she said, they're going to let me try it. But she said, you know, my cortisol is not going down. And she said, and you know, because didn't you always learn, don't ever drop cortisol, take somebody off cortisol, because it is that homeostasis chemical. You drop it, it's like withdrawal of alcohol or something. It throws your physiological system. So you always, didn't you learn, taper your steroids off. So after her surgery, they weren't about to not give her steroids. So they immediately gave her a pretty high dose of steroids, and then we're going to drop it, which is what they did. They kept dropping it post-surgery. The trouble is, her level didn't drop. It stayed up there, and they were not really perplexed because they knew they might be that danger. And so, and I'll tell you why in a minute. Anyway, so she's trying to, she said, I don't know, my cortisol's still high. And I said, well, what do they say about it? Well, they don't say. She said, I asked how she was doing with it. She said, well, it's hard. If you're now doing what the Creator fixed our bodies up to do, and she's governing it by deciding her amount of cortisol. Of course, she's under an endocrinologist who's helping her. I told her, I said, Leanne, I have some real compulsive friends that keep a little book by their microwave and hot chocolate 1.5 minutes. You know, be real compulsive. Gastritis, double it twice. You know, after you've done with the physician, headaches and stuff, and you call your endocrinologist, he says, up your cortisol, because it's stress, it's pouring out, up your cortisol, or you need it, up your cortisol 1.5 times, headache. I said, pretty soon you'll go through all the regular little illnesses, have them down here in the book, and you will know, for an upset stomach, I need to increase my, because any stress, our cortisol tries to keep us in good homeostasis, keep life good. And so she's got to up her cortisol when there's stress. It's just how much, and she needs a doctor to help her. And so I said, keep a little book, be real compulsive. Well, the next thing I know, she's in the ICU, she's had surgery, and has had an adrenalectomy. And so I went in to see her, because she was at our hospital. And she was fine visiting and everything. And I said, but she's in there because of a cortisol problem, the homeostasis problem. That's why she needs to be intensely cared for or watched. So I said, Leanne, what happened? She said, it was an emergency. And they just said I had to have, and I think, you know, sometimes nurses just do with me what you want to, and sometimes we wear them out, you know, with questions. She's one of those that just, okay. And she said, they took out the adrenal gland. I said, why? I thought it was all right. And she said, I know. I didn't understand either. And I said, well, who did it? And used to, I told you all who did it, because I couldn't stand him, and he didn't like me either. We really didn't like each other until I had his daughter in teaching, and I loved her, and she loved me, and he and I have become good friends since. So I don't tell his name anymore, but he didn't like me. I mean, he was bossy and rude and all the things that you don't like sometimes in a physician, and he had them all. So when she told me who did it, I said, ugh. She said, I know, I hate him too. I said, well, why'd he do it? She said, because it was an emergency and he was available. Imagine. So he was available and he did it. And I said, well, what did he say? She said, I asked him if something was wrong with my adrenals, and he said, this will tell you why we wouldn't have taken them out if there wasn't. That was his answer. And so, wouldn't take them out. I wouldn't have taken them out if there wasn't something wrong. Well, it made such sense, not for his explanation, but later we did get the explanation. You know, I told you her cortisol was not coming down. So the physicians knew, apparently, that when they said we'll never go back, they knew they couldn't scrape any more. But they also knew that some cells may have embedded deep, and that's exactly what happened. ACTH cells, must have been a lot of them anyway, that was shooting her cortisol up, so they couldn't get them all. And that's how compensatory the body is, that leaving a few ACT cells in her fascia, in her muscle tissue, they just woke up and started working just as hard, making up for lost cells as ever. So her never came down. They were giving her the medicine, but as they tapered it down to just a little, it stayed high because those compensating cells are trying to produce and get back up. So what did they have to do is take out the adrenals that were getting stimulated, even though they were perfect. There was nothing wrong with her adrenal caps. They're fine, except they're getting stimulated too much. So if I take them away, then I don't produce cortisol. So that's what they had to do, rather than go back up and do any more scraping. So they did need to take them out. But she's going to be on the same drugs. So she got where she could handle her cortisol, all PO now, of course, and went to Vanderbilt, and he put her on, whoever it was, eventually, put her on Clomid, and so she was able to ovulate and triple ovulate, and so she lost her first pregnancy real early, but the next one were twins, boy and a girl, and she had them. Now she had to be hospitalized a few times because remember her diet, not a great diet, beans and fries. So she had hypoemesis a lot. You have that whether you have eating problems or not, and she did. So, but she delivered them fine and moved away. She knows I always tell her story because I think it makes it so understanding of the hormones. And both people, one was the growth hormone, and then with Leanne, the ACTH. Now, sometimes with my students, we'll give ACTH occasionally. I said once. Now I've given it more than that, but you don't give it often, the actual ACTH. And then they give PO cortisol. Well, why would that be? That's when I quiz a student. Why would you give PO cortisol if I've given ACTH? Because ACTH is going to stimulate the cortisol. And so why do I need both? And the answer is, it's usually a patient that has ulcerative colitis. And steroids will cut down that inflammation. So that's a common drug, cortisol, to give inflamed areas, to calm them down, get them less angry. And they can give steroids. Let's say this person has ulcerative colitis, and they're given steroids PO to cut down that inflammation, because if they're not careful, she's going to start bleeding. The GI tract's going to bleed, start digesting its own lining, and we've got worse problems. So they give steroids to cut the inflammation. But what does the hypothalamus read with that rich blood supply? Oh, you don't need any more cortisol. And so I'm going to quit stimulating you. And if I quit stimulating, you're going to atrophy. So they need to keep giving ACTH to go against the hypothalamus. Do you follow? So that you still produce and not atrophy. So she gets over her ulcerative colitis, but she doesn't have any cortex anymore because it atrophied during that heavy dosage of PO to get her inflammation down. Hypothalamus said, don't stimulate anymore, she's got too much already. So we have got to do it artificially. Just a fascinating system, isn't it? Just unbelievable.
They still have to do that today, Lydia, as far as removing the adrenals, or is there some other kind of medication that can do that now?
As far as I know, they still have to do it.
You gotta tell us. Did she lose the weight? Did she stay with the husband? Did she have
No, he was very sweet and very chagrined that he had issued that ultimatum and she had physical problems. He was very sweet about that, and obviously they got pregnant, so they stayed together. And actually they moved to Alabama, to his home area. And so they did. She never got willowy. She never did. Now, I'd say she pretty much maintained her weight what it was. She never got willowy, and I don't know why. I mean, I don't know. Do what? Yeah, stayed with her husband. All right. Any other question? Now, Mandy had a very, very important question there. So, Ann, do you? Ann,
No, mine is just an observation. I used to work in the neurosurgical ICU, and they did a lot of that.
Oh, yeah.
Transfemoral pituitary tumor surgeries, but they always spent a day or two in the ICU to watch that wound stuff. And they all had pulleys, and it was so interesting to see that bag fill up, and it was water. It was just this color.
Oh, yeah.
And so if they couldn't get it under control, we had to give them, they call it hot salts, but it's 3% what was taking.
Okay, yes, and I'm glad you, oh, I'm, 3%. And let me, yes, I'm so glad you brought that up.
Food restrict.
Yes, and I'm just so glad you brought that up because I was about to forget it. It may be on video. 20 to 40 liters of water can fly through you. I'm glad you brought that. And it's just, what is normal? It's on your card, 1.03 or 1.03. Is that right for specific gravity of urine?
1.01 to 1.03.
Yeah, 1.01 to 1.03 is specific. That's not a lot, but it's enough to keep us normal. Thank you. The other part that Ann's mentioned, and this may, Jennifer, you can tell me this on the tape, two problems we have with fluid is, okay, now, wait just a minute before I get into it. You've got it with Addison's and Cushing's. Addison's, you're not producing enough cortisol. So it's kind of like Leanne. You've got to have the steroids. Cushing's, you've got too much. And so they've got to get rid of the adrenal gland. And Cushing's is metabolism. If it has to do with homeostasis and metabolism, you are usually obese. Well, it's everything on your list of what steroids do. They redistribute weight to the trunk, and the arms become speedily. And that's true. That whole list on your cortisols. Steroids, yeah, redistribution of fat. Their hair, you don't heal. Your skin's thin. And if you have too much, usually it's not on that list, but the hair's kind of coarse. And the buffalo neck, John Kennedy, I think that was a familiar. I think his family had the buffalo neck and chipmunk face. That chipmunk face those Kennedys have. But they say his was from his steroids. I don't know. The family seemed to have that face. But he did have that buffalo neck, and that is fat redistribution on cortisol, because he had to have that from his early years till his
You
death.
have that long skin.
Yeah, and it'll make the skin. So, Cushing's is exactly, with Cushing's, you're hypo, aren't you? Hypotensive. Where with Addison's, no, steroids make you hyper. Steroids make you hypertensive. So, now, with that being said about Cushing's and Addison's, I'll throw two more on you, and that is diabetes insipidus and SIADH. Diabetes insipidus, these are problems with the pituitary or with ADH. And syndrome of inappropriate ADH. Syndrome of inappropriate ADH. And that's what, when you said it, I remember. I wanted to tell you. They're exactly opposite. Diabetes means flow. So diabetes insipidus is a flow of water, where diabetes mellitus is a flow of sugar. So don't get them mixed up. So diabetes insipidus is you have to keep them straight because it's SIADH is you are holding fluid. So what is it doing to ADH? It's secreting ADH. SIADH, you're holding too much. The antidiuretic hormone is pouring out and you're holding. Is that right? Did I say it right? Now, before you picture the Pillsbury Doughboy, that's not what they look like. Now, I have nursed a couple of people that went into SIADH, and both of them were for benign surgeries. I don't guess any surgery is benign, but it was something real simple. And they were both packing up to leave the hospital and passed out. And so everybody thinks, call the cardiac team. And the team comes, and if you've been in Harvey team or any of those teams, that cardiac arrest teams, they come and start IV, they draw blood immediately. And the blood is sent immediately to see what's going on. And the telltale is a potassium of about 115. And you know what potassium sodium of 115. Because you know sodium needs to be around 137 to 140. And it's 115 of sodium. That's really the diagnostic immediate of SIADH, is when 3%, as Ann said, keep in mind normal saline's 0.9. This is 3%. It's not point, it's 3% sodium, to try to pour the sodium in your veins so that this water will go out. And as I said, the people don't look like Doughboy. It's just fluid that is collected everywhere, and post-surgery you kind of expect your rings not to be good, to be a little tight. But it's internally, everything inside you has holding fluid, not just tissue, but everything. So that's SIADH, where you're holding, you're putting out that ADH too much. The other is too little. And with that, diabetes insipidus, that's what post transphenylectomy do. They're just pouring the water, pouring the fluid out 20 to 40, because the antidiuretic hormone is not putting out. It's been disturbed, and so it's not putting out, and we're diuresing. And there's where the 20 to 40 with the specific gravity of 1. SIADH, the urine is not that plentiful, and the specific gravity is not bad. It might be a little, no, it's really not bad, because your fluid is kind of concentrated wherever it is, so you're not pouring it out. So they're opposite. But Jennifer, is that on the video? Okay. I think, I can't remember. I think it is. Uh-huh.
Do you know, is that what happens when people have, like, toxemia and their kidneys shut down?
She's
during
asking about
pregnancy? Because I had that, and I had it, like, really early on, and by the time I delivered, well, when I went into Vanderbilt, I weighed about 107, and by the time I delivered, I was almost 200 pounds, and my baby was only 14 ounces. But my eyes were swollen shut, and I had no ankles, or, I mean, I was just holding so
She's talking about
fluid.
preeclampsia.
So, would that have anything to do with that, or that IADH? Do you, because I know they don't know what causes that.
Her toxemia, or preeclampsia, what preeclampsia. Do you know, I can't help you a lot. A, I'm not a maternity nurse. B, I'm trying to think of a physiological reason that women go into preeclampsia or
It has something to
toxemia.
do with the placenta itself. There's something, I've heard it explained before, it has nothing to do with the job. Because there's something, because,
I
yeah,
had that with my last child, but then they also kept saying, I kept asking my husband, are you the same father as your other child? Toxemia had something related to the father's.
Oh, really?
Yeah.
I
Oh.
guess they just don't know.
I think they don't. Isn't that interesting? And what were you?
because it goes away.
It's
So
what?
It goes, the treatment is delivery.
Right,
You know?
and I lost 75 pounds in 3
Why
years.
is that?
So that's the treatment for, is like,
And my daughter was only 2.
like, if you see the clamped women, we had one that, nobody even knew she was pregnant, but she was seizing. She was clamped and she came into the ER. And here, lo and behold, she's pregnant. So it was like to control the seizures, emergency C-section. And then, you know,
And it would be cleared up.
and it had something to do with the placenta.
Yeah, they did say when I delivered, my daughter was only 2 pounds, 14 ounces. My boys were fat, like 8, 9, 9, 7. And then,
This was the
but I
third.
looked as big as I did. But then, the doctor did say after delivery, my placenta was very
And you
And
spill a lot of protein.
It was large.
You
Uh-huh,
spill
protein.
Yeah.
See, it is interesting. Both of you are saying it's probably placental,
Yeah.
and yours was 14 ounces. You said.
So it really doesn't have anything to do
I
with
don't
the-
think it does. I've
Okay, I
never,
was just
but
wondering.
it does make you think with
Yeah.
SIDH and all that. All right. I think, now I'm not through talking, but let me see. I think that's what I wanted to say. How fortunate we are, aren't we, that it works. The endocrine system, the immune system. Now, the last few minutes, I just had a few, I'm not sure if I brought them up earlier. I have a list and I want to make sure, I'm just going down it on things that I want to just add. They don't amount to any anything. Let me ask you this, they're just hodgepodge. We went over, I think we did, when we did blood hematology, and you've got the film, we went over anemias are a problem with red, leukemia a problem with white, and then thrombopenias, thrombotosis a problem with platelets. And I think we went over that, didn't we? Okay, good. Now, postural drainage, and I'm just going to throw out a few things that postural drainage, when you don't know another thing to do with a patient, maybe your private duty or whatever, they can't breathe, you've got oxygen as high as you can, there's nothing else you can do but turn on the TV and try to distract them. But it's awfully hard when somebody can't breathe for them to be distracted. And so one thing you can do is postural drainage. And then more than anything, it relieves their anxiety and think they're really getting something. How much good it does, I can't tell you, but it does something. You're doing something and they're doing something, and if anything, it gets their anxiety down. So to remind you of postural drainage, it doesn't matter where, you can be creative. I just want their chest down. If it's a chair in the room, just have them over it and lean and get comfortable. They can, any way you can get them it would be better if the chest was down. But whatever you come up with, then cap your hand and pound their back. And it just brings them down. So their anxiety, part of their air hunger is they're anxious. And I would be too. And so it does loosen. I mean, it wasn't just made up. It does loosen. But besides just loosening them up, whether that's doing a good or just they're calming. So I wanted you to keep that in mind. And then Homan's sign, I don't remember if we mentioned it or not. Homan's sign is here's a foot, and they hyperextend. And if it hurts in the calf, it's indication of a clot. And I'm telling you, that's what they say. So anytime anybody has a leg pain, I will ask them to do Homan's. Now, do your foot, bring your toes back to your eyes. And if it hurts, they say the stats are only 30% that it's really a clot. But, you know, I'm going to tell you, if they do it and it shockingly hurts, I'd say that's 100%. So they're saying that sometimes they have a clot and the Homans didn't hurt. Fine. But I bet anything, if you do it and you've got a clot, it hurts. So I always do it, the Homan's sign, but don't rely on it. So,
I know with me, when I would do that, because I learned how to do that.
Did it hurt, Sandra? Because, you know, she does clots all the time, or did.
When I do the Homan,
Mhm.
if I had one, my toes would tingle.
Okay, that's good to know.
And
It never hurts your calf that much.
No.
Okay.
But when you did that Homan, you bring your toes back, my toes would tingle, and I go, well, I got another one.
Okay,
You know.
so that's good to know that for her, it was a tingling in the toes and not the calf.
Right.
So that's good, thank you. I have this note, and I read it, and I thought, oh, I think I'd forgotten that. A high BUN, blood urea nitrogen high, you and I always remember 6 to 26. But if a BUN is high, it can mask fever. For what I didn't know, I had forgotten that if I ever knew it. And we've mentioned this, but I want to mention it again. In atrial fib, so often an anticoagulant is given because if you're in atrial fib, you're not beating strong and it making gel, your blood, and it's gelling, it will clot. So heparin so often with atrial fib. Now, I think we did mention it. I told somebody to bring it up, and they didn't. Where to give IMs and sub-Qs, maybe we've already talked about it. IMs, best 1.5 inches below the acromion process. Here's the acromion, 1.5 inches, because you're really in that deltoid. If it's muscular, we need to do muscular. If it's sub-Q, so where? All muscular. That's good. The ventral gluteal, which is right inside the pelvic bone, you know, is right here. There's a landmark you can do. Actually, I don't like there's one in your agenda on that printed stuff. They show your finger and hand. Come up here just a minute. One way you can do it, I do the landmark. I get under the arm midway, bring my middle finger down till I feel hardness, which is the pelvic bone. I lay my hand straight down toward the floor, and actually what's happening is the heel is touching the head of the trochanter. So I feel hardness, lay it down, and I straight down, and I bring this over, and that's where I'm gonna give her injection. Because it's got deep muscle there. So bring it midway. Patients say, you gonna give it up there? No, I'm just saying, Martha. Bring it come on down, and there I feel some hardness. Just lay it down. Now, if I use this hand, you can come down this way and move this finger over. And then, you can sit down. Then put an alcohol swab, so I don't have to do it again. Put an alcohol swab there and get your syringe ready in here. So that's a wonderful, because it's so deep and big. I mean, big muscle here. And then children we give in the Elastis Vaccinalis. I think it's so muscular. I mean, any place just about in the leg, upper leg, is okay because it's usually muscular. Sub-Q, my favorite place is 3 inches above the elbow because that's hardly anybody has any muscle there. And if I want it sub-Q, I want it slower. That's the reason it's sub-Q. IV the fastest, IM the next, and sub-Q the slowest of all. And if it's to be sub-Q, I want it sub-Q. I don't want it muscular. A lot of flu shots, they give it back here. You don't have too much. Not a lot of people have muscle back there. But the idea is to make it, and so to really make it sub-Q, I usually pinch up and keep a pinch. Give it with the pinch and take it out, and as soon as you're out, let the pinch go. Don't keep the pinch and come out or the medicine comes out. So come out as the pinch, but when I give it, I don't level it down. I keep the pinch up to kind of make sure it stays sub-Q. So 3 inches above the elbow I love. Anywhere in the abdomen, we've already talked about giving sub-Q insulin in the abdomen because not a lot of people have a lot of muscle in the abdomen. I still pinch up. And then one of my second best places is the scapula, or right back here. A lot of people don't have a lot of muscle right there. If anywhere you can pull up skin, it'll make it sub-Q. So here, here, and here. And then,
Is that ordered very often subscapular? I've never done that.
no, it doesn't have to be sub-Q.
Oh, just,
It's
that's your
sub-Q.
choice spot.
Yeah, that it would be sub-Q. Cachexia, you know that word means waste away. Cachexia, C-A-C-H-E-C-I-A. You know, I'm thinking, I have another place right here. I just saw it. High BUN makes fever, not mask it. Another place I have mask it. I bet it does make fever rather than mask fever. Makes fever. High BUN, you don't have good nutrition or oxygen going through. Yeah. TIA, we hadn't mentioned that. TIA, transient ischemic attack. TIAs. And that's just it, transient. It happens off and on. Ischemia attack. And they say from 0 to 30, if they last from 0 minutes to 30 minutes, just a flash, or 30 minutes, it is called a TIA. Anything more, we might call a stroke or a brain attack or a CVA. But they say TIAs, you have no residual. If you have residual, it's a brain attack. It's a CVA. And so, what is a transient ischemic attack? It's anything that's unusual for you and oh, what was that? Was it just a little quick dizziness? Do I have any reason to be dizzy? Well, I didn't eat dinner. Okay, well, it's not a TIA. But a dizzy, an aura, a black spot, anything that is peculiar, and I wonder what that was. Let it go, but it happens again next week. That's not, something's wrong, and that's when it might be a TI. What do you do about it? If you want to go to a doctor, fine, because there may be something up there. Or, the treatment will be aspirin. Because, and if it's, they say 0 to 30 minutes, you're probably not going to have any effect if it lasts that long. You're probably not going to have a residual effect, but you may have the tendency for clotting and need to be put on something. I'm just going through here, seeing what else I want to say to you. If you do, if you take care of a patient at home or a nursing home and they are ambulatory, still consider draw sheets, because you can help them so much better. You say, they don't need a draw sheet. Well, hardly any of us, unless you're bouncing around and can really jump in that bed and get yourself up, and you need a little help, it's better rather than under their arms, the draw sheet. And then a urinal, I think I've mentioned it before, but maybe not. If you take care of somebody that uses a urinal, empty it every time you go in the room, even if they've got that much versus that much in the urinal, because when a man uses it, they have to tilt it. So it might be just a little, but the tilting, it then wets the bed, there you've got a bed to make. So, and I did a private duty, and I thought of it, and then the patient noticed it. When you've rinsed it out, the urinal, and emptied the wetness, really keep doing it. Because if you don't, it settles at the bottom, the little rinse water, and the minute he tilts it, it gets in the bed. And either I thought of it or the patient told me I needed to do it. I can't remember, but I've learned from it. And we covered quite a bit. I think I told you, I think I did, but I'm going to repeat it, because it's a good thing when you're assessing a patient, and it doesn't take long. Don't take a long time because they get worn out, but do it less than 5 minutes. Do an assessment. They're so impressed. Their confidence in you is so much. And I told you, you can feel the abdominal area, but you're probably not going to feel anything, and that's good news. When you do feel something is not good news. And when I say something, you'll know if it's not right. When you listen to their lungs, we've already talked about not using rails and rongi, just wet or dry or audible. But when you do their back, I don't know whether I mentioned moon to you. And again, it's not that I need to impress the patients, but they just are so much more compliant and everything if they think you care and are doing good. They like for you to do good, and it makes it all so much better. You can probably tell if they're full by doing the front. But if you could just have them sit up and lean forward, take your fist and use this muscle, and here's the back, put it in all 4 quadrants and ask them to say moon. And it's fascinating. You feel it vibrate. If it doesn't vibrate, then they're loaded. You could tell they were loaded when you did here, but it just gives them some special attention. And it's kind of good to do it. Say moon, say moon, moon, moon. And it is kind of interesting. Do it on somebody. If you can't push your hand, you just barely put it and you can feel it vibrate. Seeing anything. Do what?
Central lines, when accessing central line, whether you're inserting your needle in the heat or you're changing the tubing, have the patient turn their head to the opposite.
Oh, good
direction so
point.
that you're not
Mhm.
breathing germs, you're not breathing germs over that. If you can't turn your head, then that's
Good. When you're, Kathy was saying, when you and I access, which you're going to be able to access, because it's so easy, but do have them turn your face. And again, they like to know you know what you're doing when you say, now I want you to turn it that way so you and I don't, you mask or whatever, so that we don't trade germs. Now, I think we talked about, just want to remind you, rolling and shaking. We roll to mix, but it's really to keep suds down so you don't draw up suds. It isn't that it ruins the medicine to shake it. It just makes bubbles. And I ask students that, why are you shaking versus rolling, or rolling versus, well, you do insulin, you roll it, and they don't tell you why. I like whys. All right, and then the last thing, and it's not that important, but I don't think we've talked about pica, P-I-C-A, unusual cravings. And help your friends and neighbors who love ice, because it's a telltale sign. It's pica to love ice and eat any unusual craving. And pica with ice craving usually means anemia. And it is so right, because I have a friend and she is on chemo, so her red cells are so down, and she just loves ice, just lives for it, because she's anemic. So, but it's other things too. Dirt, starch, dirt. Some people, a lot of times, I don't know whether they always, people that love dirt, but they'll roast it on a cookie sheet, but you know, it's just a peculiar, you and I have our peculiar eating things, and it's something about it. But I've talked to people who've done it, the dirt. I haven't talked to anybody on starch. You know, that's the starch in the box, cornstarch, and it's the same thing. Now, icing gonna hurt you. The other two aren't so good for you, cornstarch and dirt. So.
I knew a girl who had pica, and she would go behind cars and just run her finger in and just eat it.
The
And I
dirt
just
on
thought,
the car.
you get worms.
Isn't that something? And people who like dirt, they say it has a different flavor. It isn't just any dirt. They didn't just go out and get dirt. They have tried it or something. You know, they know some areas that are good.
That sounds like a mental thing to me.
It does.
So is it a craving for something your body is lacking?
Well, you'd think, because cravings, I think, usually have to do with a desire of the body.
Because when you're pregnant, I know you crave certain things. I think that's
And you wonder.
interesting.
The body doesn't always do us right, because, yes, sometimes our cravings, we really want and need what we're craving. But in this case, I don't think there's anything in the cornstarch or the dirt that we and I'm not sure that all of them are anemic, mean anemia. Something else. Oh, it's so interesting to me. It's me, but I just think it's interesting. When I work an all night and I get home, all I can think about is an egg sandwich, protein. And it's got to be, my body's wanting protein for whatever reason. I just think it's interesting. All right, that's all I know to tell you. I could probably think of other things. Can't believe it's over.